Awesome. All right, let me see if I can share my screen here. First off, I want to say kudos to you guys for hanging in there this long. It's been a long day, especially when you're staring at a screen and listening to people talk. And I don't know, unfortunately for you, you got the last, most long-winded person here towards the end, and that we are finishing a little bit ahead of schedule. I want to start off by saying I do not have any disclosures, and I want to thank the Delaware Department of Public Health and Delaware HIV Consortium for giving me the opportunity to share with you guys today. And if I can share this screen, will be even better. Here we go. How about that? Look at there. All right, guys, look at what's new in the world of PrEP. Again, my name is Angie Scott, and bear with me as we travel through a little bit of review. Dr. Adam did an amazing job discussing about our options with primary care. I'm going to go a little bit more in depth about our newest regimen, Cabotegravir, the injectable long-acting PrEP agent. And then we're going to talk a little bit towards the end about what's new and upcoming and all the exciting things that are coming down the pike, and wrap this up for us. So topics for discussion, we're going to talk a little bit about those studies, the two studies that looked at the long-acting injectable Cabotegravir, the HPTN-083 and the HPTN-084. We're going to give a few drug facts, go into a little bit more explanation, dive a little bit deeper into some of those contraindications, talk a little bit more about the concern for drug resistance, which I think is kind of hanging over Cabotegravir's head a little bit. Some patient education, including some attitudes and experiences of patients of different populations, and then a little bit about financial assistance, because that is a huge barrier to PrEP for some folks, and then limitations on acceleration for PrEP, and then opportunities and aspirations for the future longevity of PrEP. So looking at the two studies, the HPTN-083 and the HPTN-084. These are basically, this slide shows side by side, almost identical type studies in terms of study design and study phases. So both arms, one of them was a study of long-acting Cabotegravir in cisgender men and transgender women who have sex with men, and the other one was specifically just looking at cisgender women. Locations were slightly different, but inclusive of a broad range, and timeline was actually pretty similar as well, both taking about 3 years to complete. I think this HPTN-084 was a little bit longer, just because of the monitoring of that tail end of that PK that Dr. Adam was talking about. In the phases, both received 5 weeks of daily oral pills. Phase 2 was injections, and then phase 3 was a follow-up of oral pills at the end. Incidentally, this was a double-blind study that was done, and so neither the participants nor the people that were running the study actually knew who was taking which injectable or which pill. So it really gave some great insight into the results themselves. Again, just another little slide to talk about the primary endpoint, which was the incidence of HIV infection. Again, there was a optional oral lead-in that they did take part in. The one arm did do TDF-FTC, or the Truvada that Dr. Adam was talking about, and the other arm did do an oral Cabotegravir as a lead-in up until week 5, and then began the double-blind phase of up to 150 weeks of the injectable. Would that be the long-acting Cabotegravir, licensed under the name Apretude from Beebe, or the placebo. So digging a little deeper into the HPTN-083 study, it was the first study to compare the efficacy of long-acting Cabotegravir to oral TDF-FTC for HIV pre-exposure prophylaxis. Again, it enrolled about 4,500 cisgender men and transgender women who have sex with men throughout many countries. And the conclusions that came out of that were that both agents, both oral and injectable, were highly effective in HIV prevention. that the PrEP regimen containing cabotegravir long-acting was actually superior to an daily oral regimen of TDF-FTC with a 66% reduction in HIV infection receiving the cabotegravir compared to the TDF-FTC. There were some, almost nearly all of them had an injection site type reaction, whether that different grades that were, but overall was well tolerated. Of note, those folks who did have the injection site reactions did say that they wouldn't not take the injectable cabotegravir because of the injection site reaction. So they would still continue the study, knowing that. This study, just so that there's some transparency there, it did include MSM and transgender women age 18 and up. The risk factors that identified these folks for this trial were any non-condom use of no condom with the receptive anal intercourse, greater than 5 partners, anybody that used stimulant drug use, incidental rectal or urethral STIs, such as syphilis, because we do realize that STIs do put people at increased risk for HIV acquisition past the 6 months, or here in the US, we use, in some instances, the Sex Pro score, and that would be a Sex Pro score of less than or equal to 16. In general, these folks were all in good health. None of them had hepatitis B or hepatitis C. So again, as Dr. Adam was stating earlier, you do want to screen for hepatitis when you're looking into assessing somebody for PrEP. However, these folks were not, did not have a co-diagnosis of hepatitis to be able to be in this study. They did not, also could not have a contraindication to gluteal injections, history of seizures, and we'll talk a little bit more about that in just a few minutes as to why that is, or any skin conditions. On the HPTN 084 study, this was, it's also called the LIFE study. This is the first and only study comparing cabotegravir LA to the oral TDF-FTC for pre-exposure prophylaxis exclusively in cisgender HIV uninfected women. It enrolled about 3,000, a little over 3,000 cisgender women 18 to 45 years old in sub-Saharan Africa who are at risk for acquiring HIV. The conclusions for this study were that a total of 39 HIV infections occurred during follow-up, with 3 of those infections in the cabotegravir LA arm and 36 in the TDF-FTC arm. So what they showed was actually quite astonishing. Approximately 12 times, the participants were 12 times more incident had 12 times more incident HIV infections with the TDF-FTC than in the cabotegravir arm. This means that the trial participants who took injectable cabotegravir had a 90% less risk of getting infected with HIV compared to those participants who took oral FTC TDF. And that, of course, meant that these met the statistical criteria for the superiority of CAB-LA compared to TDF-FTC in this particular study population. Just as Dr. Adam was saying, I think that the reason for this, or that one of the conclusions you can come from this, is that there was a higher than expected level of adherence throughout the study, and the overall incidence rate for both arms of the study shows that both drugs were highly effective at preventing HIV. So although there was significant benefit seen in the CAB arm, the TDF-FTC also showed wonderful results as well. So not an exclusion process there. Drug facts. So we're going to talk a little bit about indications, contraindications, go a little bit more in depth there. We're also going to kind of target the big elephant sitting on the opposite side of the room and talk a little bit about that drug resistance and why there's such a talk about it with especially the long-acting cabotegravir. Some patient education surrounding attitudes and experiences of the different populations, and then some financial assistance discussion. So indications, who is this good for? Who can use this cabotegravir injectable? So Cabotegravir LA is manufactured, and again, we try not to use trade names, but I feel like it's important to disclose this here. It is manufactured and licensed and sold by Beebe Healthcare under the brand name Apretude. So I will say that for the next few slides, the information that are on these slides is actually coming from the full prescribing information provided with that particular medication. Apretude is an HIV-1 integrase strand transfer inhibitor, or you'll hear them called, or I'll probably reference to it many times as an INSTI, indicated in at-risk adolescents and adults. And by adolescents, everybody's kind of got their own definition of that, but I'm specifically kind of looking at those perhaps 12 years and older who weigh at least 35 kilograms or 77 pounds. And that really is the cutoff, is that weight limit there. For PrEP to reduce the risk of sexually acquired HIV. Individuals must have a negative HIV test before initiating Apretude with or without that oral lead-in. So dose and administration. This does come in a single dose vial, 600 milligrams per 300 ml of cabotegravir extended release. Suspension, and it has to be started on the last day or within 3 days of that oral lead-in. After the injections are started, there is a 7-day window before or after, but I wouldn't, in my experience, I don't share that with the patients necessarily right off the bat. I just kind of let them know that this is the date that they've got to be back, and we try to make that work for their schedules. Again, screen all individuals for HIV immediately before initiating the Apretude, and then again, before each injection while taking the Apretude is what the manufacturer is recommending. Before initiating it, an oral lead-in, of course, can be used, and that is for approximately a month or 28 days to assess the tolerability. In this particular case, if you got somebody that has, a laundry list of allergies, or they're particularly a little finicky, this is a good time to kind of use that oral lead-in just to kind of let them get their feet wet in it a little bit. It is for gluteal intramuscular injection only. So again, like Dr. Adam was saying earlier, it is highly specific. It's got to be given by somebody who's trained on how to do that. Giving a patient giving this to themselves at home is really not going to be an option at this point in time, although we'll talk about that towards the end about some ideas for the future. The recommended dosing schedule, we want to initiate the Apretude with a single or a 3 ml injection. That's a lot of medicine, given 1 month apart for 2 consecutive months on the last day of the oral lead-in or within 3 days, and then continue the injection every 2 months thereafter. Of note, because I know this will come up, individuals who miss a scheduled injection should be clinically reassessed to make sure that this injectable medication is suitable. Also, longer needles sometimes are required than what's actually packaged in the medication itself for those folks who may have a larger BMI, just to make sure that the medicine's going IM instead of sub-Q. And we'll go to the next slide here. The contraindications, who do we not want to use this for, or who do we want to kind of take a closer look at before we consider this as an option? Those folks with an unknown or a positive HIV status, those folks with a previous hypersensitivity reaction to cabotegravir, or co-administration with drugs where significant decreases in cabotegravir plasma concentrations may occur. And these are specifically anticonvulsants and some of the antimycobacterials. Anticonvulsants that we're talking about are like the carbazepine or the phenobarbital. Antimycobacterials, I'm talking specifically rifampin and rifapentine. Warnings and precautions. Comprehensive management to reduce the risk of HIV acquisition. So again, PrEP doesn't mean that we don't talk to our patients about the other ways that they can protect themselves. This is just one tool in that whole arsenal, that whole toolbox that we're going to be able to give to them. So they still need to be making sure that they're getting regular STI testing. We need to be having conversations about barrier protection. We need to be talking about, how many sex partners do they have, and ways that they can help reduce the risk that way. So again, it's one of the tools in that entire toolbox that we're going to be giving to our patients, not a one size fits all or a one fix it kind of a thing. Potential risk for developing resistance to cabotegravir, and again, we'll talk quite a bit about this in the next upcoming slides. If an individual acquires HIV either before or after taking Apretude or following the discontinuation of Apretude. So we need to reassess the risk of HIV acquisition and test before each injection to confirm the HIV negative status. Residual concentrations of cabotegravir, as Dr. Adam was saying, may remain in the system circulation of the individuals for up to 12 months or longer, according to some studies. And then hypersensitivity reactions have been reported in association with other integrase inhibitors. So if they have hypersensitivity reactions to other things like dolutegravir, then we may need to rethink our plan here a little bit. Hepatotoxicity has been reported in patients receiving cabotegravir, although it's extremely rare. So just monitor clinically and with labs, monitor their LFTs and things like that, and discontinue if you start to see that spike come up. Depressive disorders, one of the things that's not talked a whole lot about. We know our folks, especially in the LGBTQ plus community, do have a higher propensity towards depression. So we want to make sure that we're screening these patients for depressive disorders when we're talking about this particular medication. Prompt evaluation is recommended for any depressive symptoms. Adverse reactions, the most common by far and large is the injection site reaction. So these are the, I've got a redness, I've got a hard lump, I've got soreness at the injection site, those sorts of things. The median duration of those injection site reactions was about 8 days. And then again, those, and it did tend, as they continued their injections, to decrease over time. So their third, fourth, fifth injection, those injection site reactions got fewer and fewer. And as I stated earlier, most folks that were in these trials did not want to discontinue the long-acting cabotegravir as a result of those injection site reactions. Other adverse reactions, of course, they have to list everything from A to Z, whether it was actually directly related to cabotegravir or not. So everything from diarrhea, headache, fever, fatigue, to flatulence, abdominal pain, myalgia, sleepiness, back pain, and all those other wonderful things. Drug interactions. So drugs that induce, and I am not even going to pretend like I know how to pronounce that last word. So we're just going to call them the UGT 1A1 or the 1A9, may significantly decrease plasma concentrations of cabotegravir. So these are your anticonvulsants and your antimycobacterials that I referenced earlier. Clinical monitoring is recommended, and again, this is coming straight from the manufacturer's package. Clinical monitoring is recommended for patients taking methadone, not meaning that they need a dose adjustment when they're starting the Apretude, but more so that we just may want to take a look at maintenance therapy as they're on this for longer periods of time. Use in specific populations, and again, we'll talk more in depth about cabotegravir and pregnancy and patients with a potential for becoming pregnant in a few slides ahead. But lactation, our patients who are lactating, we need to assess the risk benefit of using Apretude to the infant while breastfeeding, because the potential for adverse reactions and residual concentrations in the systemic circulation has been documented for up to 12 months after discontinuation of that medication. And that's not a population that's been readily studied with this medication yet. So just kind of use your judgment, risk benefit there. Pediatrics, this is not a medication that's recommended, again, in individuals weighing less than 35 kilos. There is, of interest, there is an open label study for adolescents underway for this medication. And a question I get quite a bit, especially here in Sussex County, is because we're seeing a lot of retirees moving to the area, is our geriatric population. So if the patient is geriatric, there's no changes necessarily needed to monitor for that, other than what you would typically do for the older population, just monitoring their renal, cardiac, and hepatic functions, and then also kind of watching their the other drugs that they may be taking concomitantly with the medication. All right, here we go. The big ugly beast in the room. Everybody wants to talk about, what about resistance? And again, not saying that cabotegravir causes resistance, but there is, this idea out there that if the longer acting that you have, the longer of a PK tail that a medication has, and then that those waters get very muddy about when somebody actually no longer is virologically suppressed with the medication. So what are the concerns here about resistance? So the incidence of HIV infections occurring in people on PrEP may have delayed seroconversion. So these are folks that are, kind of what Dr. Adam was saying, is their ability to show up on an HIV test may be delayed because of those lower levels of medications still there that are prohibiting that conversion, or for them to be showing up as HIV positive. Using the same drugs and drug classes for both prevention and treatment, some folks are saying it increases the risk of resistance and failure of both approaches. That is a concern out there, although I think for the most part, you've got to have multiple mutations really to kind of really put a pin in that theory. Implications of delayed HIV diagnosis, including the development and possible transmission of HIV or resistant HIV. And there is some study that does show that there is a delayed HIV diagnosis, or the potential for delayed HIV diagnosis when you have this kind of weird tail off of therapy. The longer half-life of cabotegravir versus TDF may explain the higher relative risk of emergent class drug resistance per incidence of HIV infection for the cabotegravir than for the TDF-FTC arm. And then implications for cabotegravir associated. So why is it a big deal? Why is this a big deal, especially for those of us that are on this call that are not necessarily infectious disease providers? So saying resistance, what does that mean? That means that due to these mutations, it could be and I use could very broadly, associated with virologic failure with both dolutegravir and bictegravir, because they're both in that same class that would impact the second generation INSTIs. So, and the reason that's an issue, we continue to go down this kind of like what if trail, is that those two drugs are kind of the backbone for all of the first line antiretroviral regimens currently recommended by the NIH. So how can we be extra cautious? How can we still utilize the benefits of cabotegravir and still address the big elephant in the room and take care of some of the concerns? So there is updated screening recommendations for folks on PrEP, as Dr. Adam alluded to. New CDC guidelines recommend the addition of an HIV viral load screening for all those on PrEP. And what this means is that you have a dual use of the HIV antigen antibody screen and the RNA testing, rather than just the antigen antibody testing for individuals on PrEP. The rationale for that comes from the analysis of the HIV infection incidence in the HPTN 083. So out of those two studies that we were using to assess for cabotegravir, this kind of showed up as a result of that, showing that antigen antibody assays are unpredictable for individuals on PrEP because they can remain negative or indeterminate for several additional weeks after acute infection. The data from the HPTN-083 shed key insights into the phenomenon of delayed seroconversion. A retrospective analysis of 51 of the HPTN-083's participants showed 52 incidents of HIV infections and of the delayed detection of infection in several cases. So in the CAB arm, 7 of the 12, so 58%, a little over, incidences were not detected on routine antigen antibody testing at that visit, leading to a mean delay of diagnosis of 98 days. And for somebody that's on PrEP, you know, I don't know how much, I'm sure, anyway, there is a gray, a muddy area that we're talking about here, where there's a potential where we could be building up some resistance during that time frame, because it is rather delayed, especially when you compare it here to the TDF-FTC arm, where delayed detection was found in 7, so 17, almost 18% of the 39 incident cases, with a mean delay of only 31 days. So it's a much shorter duration. Even though there is a delay, it's much more condensed. However, viral load testing detected infection in 5 of the 7 cases in the CAB arm and 6 of the 7 cases in the TDF-FTC arm. And then also of note, just so that you have in the back of your head, reversion of the antigen antibody assay from reactive to non-reactive was also reported in that Cabotegravir arm. So you could kind of see that wave effect where they kind of showed up positive and then went non-reactive. Again, so again, that just leads to that muddy kind of in-between area. Cabotegravir can persist in the body for a year or more is what the studies are saying. And again, it's due to that long PK tail, which increases the period of time for risk for breakthrough infection and selection of cabotegravir resistance. Incidentally, higher BMI range was associated with a later time of last measurable cabotegravir plasma levels. So there does need to be some further investigation to determine that concentration in which HIV protection is lost, kind of what we were talking about a little bit earlier. So again, just something to be mindful of, be aware of, have a discussion with your patients, especially if they are of a higher BMI, especially if they are a female that's considering, you know, reproduction, childbearing, that sort of thing. Patient education. So you as a provider, you as a caseworker, what do you need to be able to share with your patient? A couple of things. First off, I think it's helpful to understand the attitudes and experiences of different patient populations, because again, this is not a one size fits all. We all know that we've got patients that are all over the place as far as what their lifestyles are, what their needs are, and where they want to be, you know, in a few years from now. So financial assistance information, and then what the provider should discuss with the patient when you're in front of them. So I just took a couple of just studies and kind of threw them in here. I'm not going to read through all of this with you guys, but just attitudes and experiences of different patient populations. So there was a study among MSM of color in New York City that took in-depth interviews of about 26 male participants in 4 different types of clinical settings and evaluated them for preference of a daily pill or an injection every 3 months. And this was kind of prior to long-acting cabotegravir getting FDA approval. And so it was a study that was taken and saying, okay, if you had the choice of every 3 months of an injection or a pill every day, which would you prefer? What they found is that 79% of those MSM of color would prefer a periodic injection. The interest in using cabotegravir LA to avoid, quote unquote, their words, one stupid mistake, allowed for greater assurances against the possibility. And it was more pronounced among the MSM who more commonly reported or self-reported engaging in multiple sexual partnerships than in the heterosexual participants. So cabotegravir LA, according to one patient, said that he said it affords more confidentiality and privacy than oral daily pills. That was interesting to me because I would think that a pill you would be able to take kind of like on your own. But for some folks, I guess, taking a pill every day, especially if you're living with somebody that you don't want to disclose that you're taking this to, it could be a little bit more of a confidentiality issue there than with the injectable. The privacy and the lack of stigma were seen as an additional advantage of the injectable cabotegravir. Feelings of invincibility and an increase in condomless sex were reduced. And this was another thing that surprised me. They were looking at a group out of San Francisco with this one, where it said because more of the frequent reminders to stay safe when they're getting their injection. So as these participants were coming in to get their injection, the providers were using this as an opportunity again to have more conversations about the other tools in their toolbox, about using barrier protection, about making sure that they are staying safe, and decreased number of sexual partners and how to protect themselves in other ways. So the feelings of invincibility that were increased with condomless sex were actually reduced because they were having those constant reminders. They weren't just taking a pill and then not coming back for 6 months and having that reminder at that point in time. There was another participant study in a nationwide sample of Black women in the U.S. and these women, I believe, had similar geographic distribution of the respondents that were similar to those across the U.S. So this was a sample that was pretty representative of what you see in the entire United States. Of those 315 respondents, 32% were aware of PrEP and 40+% were interested in using it. That actually, for this particular subgroup or this population, the interest in PrEP actually increased if the PrEP was provided for free. So you can see with this particular group that were being studied that it was actually a barrier of financial constraints. If they knew that it was free, then they would most certainly take up more options for PrEP than if they had to pay for it out of their own pocket, or if they had to, perhaps utilize some other form of payment. Oral PrEP in this particular group, which was surprising for me, and I guess it's maybe more control. I guess it could have been because they were already used to maybe taking oral contraceptives. Oral PrEP was preferred 62, almost 63% over long-acting injectable PrEP. And then it was preferred because they said that, again, the reduced cost and then the PrEP-related stigma was reduced for them by taking the oral daily regimen. So as you can see, it's kind of like all over the place. And it's a discussion that needs to involve the patient. This isn't something that just the provider themselves can make that decision for. So when looking at cost, there are multiple different options here. Cost should not be a barrier for anybody, at least here in the state of Delaware. There's a program, Ready Set PrEP, that offers low or no cost for those who qualify. That is through the CDC's website. And as Dr. Adam was saying, federal law was put into place that ensures or requires insurance plans to cover certain items that are related to PrEP, including the labs that are done as a necessity to be able to prescribe that for the patient. There is copay assistance programs. There are copay assistance programs out there where income is not a factor. So somebody's on a private insurance and may need a little help. There are copay assistance programs out there that won't necessarily factor in their income, but just kind of use their insurance as a buffer. Beebe Connect is a program that has a whole host of different things. They have an Aptitude savings program, which includes e-vouchers, Beebe savings cards, rebates. The patient assistance program is where the patient has no insurance. These would be good for our uninsured population. They help based off of financial need. I will say that Medicare and Medicaid is variable. Medicare is particularly tricky because of the restrictions. They're not able to utilize the copay assistance programs as much. This is one of my my biggest, if you know me at all, this is like one of my big things with Medicare is the whole donut hole, the whole use the medical side of the benefit versus the pharmaceutical side of the benefit, and the costs that are associated with each one. So Medicare can be a little tricky, but I would stay persistent. There are some prior authorization support helps on the Beebe Connect program on their website. And then sometimes you do have to, send in that certificate of medical necessity as a provider, and they do have sample ones of those online too that are helpful. So what should the provider discuss with the patient? You got the patient in there, we figured out the cost. Patients come to you and says, hey, I'm interested. What can you tell me about this? So as a provider, you need to let the patient know that before receiving the long-acting Cabotegravir to reduce HIV, the patient must be HIV negative. We do have to do those lab tests. Some tests can miss infection in a person who's recently infected, so we do need to ask the patient about any flu-like illnesses within the last month before starting the long-acting Cabotegravir or any time while receiving that injectable. Cabotegravir does not protect against pregnancy or STIs. Very important. Again, it's just a tool in the toolbox. So we need to remind patients at each visit to practice safer sex by using barrier protection, such as a condom. And then also to remind patients that having STIs can make it easier to acquire HIV. And I think this is a huge point that most patients just assume that because they're on PrEP, then if they get an STI, I'll just, I'll go get treated for that. There's a pill for that, right? There's always a pill for that. So the issue with that is that if they have an STI, if their partner has an STI, that does raise the risk of acquisition of HIV. So we want to make sure that they're using all their tools. Patients should not miss doses, and missing injections will increase their risk of HIV. If the patient's going to be missing their injection by more than 7 days, then they absolutely must contact their healthcare provider right away to discuss other options. One-time deal, perhaps we can get them switched over to something else. If this is an ongoing issue, we may need to look at, is this particular route of PrEP the best way for this patient? Patient needs to know that there may be side effects, including allergic reactions, liver problems, depression, and/or mood changes. And again, you always remind the patient that they should seek immediate medical attention if they are developing any kind of swelling of the mouth, eyes, lips, nose, face, tongue, any of those sorts of things. And then also seek immediate medical attention if they are feeling like they want to harm themselves or feeling thoughts of hopelessness. Most common side effect is injection site reactions. We did kind of review that earlier. Patients should tell their healthcare providers about all the medications they are taking every visit, including OTC, vitamins, and herbal supplements. This is even true of our HIV patients, right? They come in and they've got these blips in their viral load. And I'm looking, what is going on? You ask them to go through their med list like 3 or 4 different times, and they still, oh no, that's exactly what my mess. And then come to find out they're taking, ashwagandha or some sort of blackberry root, something, I don't know, that, is the culprit. I saw this weight loss thing on Amazon and I ordered, I want to make sure that I'm not gaining any weight as a result of, my medication. So just make sure you're having that conversation with your patient. So special considerations, I told you we would talk about this to kind of cover this. Women of childbearing potential. So updated Centers for Disease Control and Prevention guidelines do give multiple options, list multiple options for PrEP for men who have sex with men and transgender women, including the once daily TAF, FTC, and the daily and on-demand tenofovir, intracetabine, the TDF, FTC, and now this long-acting Cabotegravir. Where it's not as helpful is particularly for these cisgender women. FDA only has 2 approved options for PrEP, and that is again the oral TDF FTC or the Truvada, and the Cabotegravir LA or the Apretude. The TAF FTC is currently, just as a note, being evaluated for PrEP in patients at risk for HIV infection due to receptive vaginal intercourse, but it's not currently approved for that particular indication. So it is approved to treat cisgender women with HIV when used in combination with other antiretrovirals, regardless of pregnancy or childbearing status. But because it wasn't specifically studied for PrEP as an indication, it has not been given FDA approval. So there may be some confusion there, but Truvada, Cabotegravir LA definitely have the FDA approval. The Descovy is in the works, even though it is being currently used for treatment. Although the FDA approval for PrEP and treatment of HIV includes women of childbearing potential or women actively trying to conceive, those who are using the Cabotegravir LA in these settings present distinct challenges, which providers should be aware. And we talked about that, right? There's a couple of different things here. So the long-acting, the tail, again, can be an issue because we don't know how this will affect the child or the fetus during that first trimester of pregnancy if the woman has just finished taking the Cabotegravir LA. The other thing is a lot of women of childbearing potential will use the injectable form of contraceptive, so like the Depo-Provera shot. And you can't give the Depo-Provera shot and the Cabotegravir LA because they're both given the same way, the same gluteal area. You can't to alternate those sites. There is an issue there as well. And that's kind of what we talked about here is women who can conceive up to 1 year or more after discontinuation of PrEP with long-acting Cabotegravir may have some significant levels, including that during that first trimester. Without appropriate preconception counseling, many women may not be aware of this. So again, it's another thing to be talking to your patient about. And then exactly what I was talking about, the logistical issues of the asynchronous timing of the injections may create some adherence difficulties for patients. So if they're coming in 1 month to get the Depo shot, but then coming in, the next month to get their Cabotegravir shot, and then another, it just kind of throws them off. And the whole point to all of that really was to not have to think about the timing of everything. So additional data is kind of needed to discuss the safety and the efficacy of CAB in pregnancy. And so providers may want to be a little cautious when kind of looking at that from a women in reproductive potential stage. So opportunities and aspirations for long-acting injectable Cabotegravir and beyond, to infinity and beyond. So the goal here obviously is to end the HIV epidemic. We most certainly cannot do this alone, as the panel was discussing with Brian, Tyler, and Dr. Call. It really will take everyone to end the HIV epidemic. So some of the things to consider, kind of looking ahead at Cabotegravir and the other things that are on the horizon. Beebe is the developer and will be the sole supplier during this initial period where Apretude is our long-acting Cabotegravir is sold under the name Apretude. So pricing is going to be important during these initial first few years. Voluntary licensing to generic manufacturers will have to come into play to provide that diversified product supply. Provider training like this, getting out there and teaching not just the providers, but the clinic staff, the counselors, the HIV screeners, all of the folks out there that have a chance to touch these patients. Training needs to be available so that we can dispel any myths that are floating around. The testing requirements, and again, Dr. Adam did touch a little bit on this as well, as sometimes insurance or the patient's uninsured, those testing requirements can be more of an expense than the actual medication. So just being mindful of that, understanding that, yes, there is the new recommendation by the CDC for the two-step testing process in the long-acting Cabotegravir, really for all PrEP, but you've got to weigh the risk and the benefits and kind of know your client as well. Data needs to be collected still on the benefit of injectable CAB as PrEP population signs not part of the efficacy trial. So, okay. So basically, we just need some more information on some of those other demographics. So the adolescents, the pregnant, the breastfeeding people, the transmasculine and gender nonconforming individuals. Research studies on alternate injection sites, again, to consider alignment with injectable contraception. Years ahead in HIV prevention research. So this is, I love this chart because it kind of gives you some look into the future about where we've been, where we're going as far as research goes and what's out there. So there is dapivirine, a vaginal ring that's currently being studied in South Africa that could be used as opposed to an injectable or a daily pill. This is a once monthly ring, kind of similar to our contraceptive, the Nuva ring, if you're familiar with that. So it is out there. Looking forward to some results from that to figure out if that's going to be something that's another tool for the toolbox. Another long-acting injectable is out there, lenacapavir. So this needs some additional information. There are some additional regulatory approvals, WHO recommendation and early introduction. So this is an injectable that should be, right now what they're saying is efficacy trials of up to 6 months. So even longer than the long-acting cabotegravir, this lenacapavir is supposedly once every 6 month kind of injection. So again, another tool for the toolbox. A dual prevention pill. So this would be oral contraceptive combined with like a TDF FTC. So that's down the pipeline. Boy, wouldn't that would be something too, I think. Oral PrEP. So there is continuation of oral PrEP in studying in cisgender women. So just making sure that our Descovy folks are being equitable with our women of reproductive age. And then a combination of or a preventative vaccine. I know that is, there's an efficacy trial going on among MSM and trans people for that one as well. So looking at research, oops, got too far ahead of me. Looking at biomedical HIV prevention trials. Some of the trials that are going on are some of the same things here. The other things that they're looking at are antibodies for HIV prevention in the HPTN 085 and 081 trials, the preventative vaccine, and then this is a cool one. I'm kind of excited to see this. It's not really out in the works yet, but a PrEP, combination of PrEP and HIV vaccine in one. Which would be interesting. That's an interesting concept. So the bottom line here is, folks, is again, there's all kinds of stuff. It is within reach to end our HIV epidemic, not just in the US and the world, but here even in just Delaware. But it will take all of us. It will take everybody to diagnose, treat, prevent, and then respond appropriately. My shameless plug here is that that I wanted to share a few of my own personal Beebe Healthcare heroes. So these are the folks that did assist with this year's AIDS Walk Delaware in Rehoboth Beach. We were giving Mpox vaccinations to our folks there at the walk. In addition, we've got some folks here that are willing to share the love, I call it, by rocking the red ribbon at this last AIDS Delaware or AIDS World AIDS Day. So kudos to these folks, kudos to you guys, and thank you again so much for sharing this day and this time with me.